I'm going to discuss is mechanical circulatory support. I know I don't have any disclosure for this talk. So once we are dealing with a patient of acute heart failure, the time is limited, so we need to really go back to bedside and see two things: whether the patient has congestion or not, and whether this patient is having hypoperfusion or not. So you can find congestion by simpler signs like pulmonary congestion, orthopnea, PND, peripheral edema, jugular venous dilatation, congestive hepatomegaly, and perfusion can be assessed by whether patient is having oliguria, mental confusion, dizziness, and cold sweated extremities or not. So it is this group of patients who are having both congestion as well as hypoperfusion are very, very sick, and they are known as cold and wet. So these cold and wet patients, they can be hypotensive also, and if they are not hypotensive, then the primary treatment is vasodilators and diuretics. Inotrope can be required if the patient has a refractory situation. However, these patients who are having hypotension as well, they need inotropic support as the first line, and the vasopressor may also be required. However, these patients have very high mortality, and in these patients, we can use mechanical circulatory support if there is no response to drugs. So what is the aim of this mechanical circulatory support? The aim is to resuscitate the patient and maintain end organ perfusion, allow stabilizing measure like angiography and revascularization, limit and reverse myocardial injury, unloading left ventricle, and influencing cardiac remodeling, which is a newer indication with Impala. So what is the indication for mechanical circulatory support? Estimated 80% mortality on conventional supportive treatment. That means when the patient is on high dose inotropes, the mortality is very, very high. So this is the time when you should do something better for this patient. Cardiogenic shock requiring 2 or more inotropes. And MCS is indicated only if the condition is acute, severe, life-threatening, reversible, and the patient is unresponsive to conventional treatment. Otherwise, there is no benefit for instituting the circulatory support. So when to institute the circulatory support? This is not an individual decision. You should involve a team which is known as shock team, and the team will evaluate these parameters. What is the etiology and course of acute heart failure? What is the treatment administered, whether the patient is having rapid increase in hemodynamic support, and what is the clinical status? And echo, if it shows very low cardiac output, then this is also one of the indication. So the early institution is the key, because the problem which is only hemodynamic to start with and can lead to recovery if you act fast may lead to hemometabolic problem where the later on multi-organ failure sets in, and these are the patients who are not going to do well in the course of illness. What are the types available? The devices available are intra-aortic balloon pump, Impala, tandem heart, VA, ECMO. Long-term support devices are not the treatment of choice in this critical cardiogenic shock, which is an intermax class 1 patient. So we all have intra-aortic balloon pump in our centers. It is a rhythmic inflation-deflation device. It is percutaneous, requires very little anticoagulation. It can be used for up to 5 to 7 days. It increases diastolic blood pressure, it reduces afterload, reduces myocardial oxygen consumption, and increases coronary perfusion. The problem is that cardiac output is not markedly increased. This is a typical IBP pulse, where you can see that this is the systolic pressure and the diastolic pulse goes down. And at this point, the IBP inflates, which leads to, at the onset of the diastole, the IBP inflates, so that this leads to diastolic augmentation, and which increases the coronary perfusion. At the end of the systole, the IBP deflates, which leads to a suction-like effect, and which lead to decrease in afterload, reduced cardiac work, reduced myocardial oxygen demand, and it improves cardiac output. The other device is tandem heart, which is percutaneously placed short-term VED. You take blood from the left atrium through a transeptal puncture and through a centrifugal pump send it back to the femoral arteries. This is a LA to aorta pump, and it is also percutaneous. It has requires high anticoagulation. The duration can be a day and few weeks. So it reduces the filling pressure and preload, because you are draining from the LA. You are reducing the myocardial oxygen demand. You are reducing the myocardial oxygen work. But the problem is that you are increasing afterload, because you are ejecting blood retrogradely into the femoral arteries. It reduces LV valve stress, because you have drained the left ventricle and hardly any blood is going into the left ventricle. So the oxygen consumption of the myocardium is reduced, and it provides good support of 5 liters per minute. The another beautiful device which is available in our country now is Impella. This is the very physiological choice because it is LV to aorta pump. It is percutaneous. It requires anticoagulation and can be used for a few days. It reduces filling pressure, it reduces LV wall stress, it reduces LV work, it reduces myocardial oxygen consumption. So overall, the best reduction in all the parameters is achieved by Impella. However, the support is not too great. This is an Impella catheter. You can see that this is the part which remains. So this part goes into the ventricle, and this part remains outside the body. And there's a very miniature pump which has an impeller attached to it, and it rotates at high pressure, which sucks blood from the inflow and ejects it into the outflow. There are multiple devices available in this, which is Impella 2.5, Impella CP, Impella 5, Impella RP. RP is the right-sided device. Impella 5 is surgically implanted. However, Impella 2.5 and CP are percutaneously inserted and have shown benefit. This is a typical protected PCI situation where a single SVG lesion, which is the only surviving graft, and if you start with a mean arterial pressure of 86, if there is no Impella, as soon as you inflate the balloon, the pressure starts falling down, and patient may enter into a cardiogenic shock spiral. And you can see that there is a 51% reduction in the mean arterial pressure in this patient, and patient may not recover later on if you deflate the balloon. However, if you put this patient on Impella, the mean arterial pressure goes up to 110, and even if once you inflate the balloon, after 45 seconds, because of the pump, the circulation is maintained through Impella, the mean arterial pressure is not too much down, and it's only 12% reduction in mean arterial pressure, and patient continues to have vital organ perfusion. So these patients can have a PCI in a better form. Another indication for Impella is this cardiogenic shock indication, where when you can stop this reverse spiral and you can initiate myocardial recovery, and the native heart recovery becomes our goal here. So Impella improves flow, increases MAP, which leads to increase in cardiac power output, and cardiac power output is one of the most important parameters for survival in cardiogenic shock patients. It also reduces LV-EDP and LV end-diastolic volume, which leads to reduced involved traction and reduction in mechanical work, leading to increased oxygen supply to the coronaries and reduction in the oxygen demand, which leads to unloading and myocardial recovery. CVAD registry had shown that patients who had Impella in cardiogenic shock situation in acute MI before PCI, they showed a significant benefit. So this is a patient which we did on Impella, 86-year-old gentleman who had near shock situation, unstable angina, triple vessel disease, global STD changes, and you can see that RCA and left system is very badly diseased, heavily calcified, and the patient turned down, and so we put the patient on Impella. That's how Impella looks in the left ventricle. And then a rotablation dilatation with the stents was done, and you can see that this is the end result on the left side, and this is the end result on the right side after rotablation and stenting. So coming to another support, which is ECMO. ECMO can be used in two configurations, either veno-arterial ECMO or it can be used in a venous mode, which is primarily for lung support. Our concern here is veno-arterial ECMO, which is a RA to oxygenator to aorta flow, and it's percutaneous, anticoagulation is required, and duration is weeks. However, it increases filling pressure and preload, it increases afterload, it increases LV wall stress and LV work. So it is overall not a very good, very good device for the LV support. It's a good circulatory support device, but not a good LV support device. So I would just briefly show you one case which happened in our institution for TEVR, and I was as a standby, I was there in the room. So this was a patient who who had to go for valve in valve procedure, who had failed prosthetic valve in the aortic position earlier. The ejection fraction is, you can see that it's around 40%, and very large gradient at the aortic valve. The patient was taken up for valve in valve procedure through TEVR, and as soon as they did a pre-dilatation, after pre-dilatation, there was no pressure, and patient simply crashed. And what happens, the possibilities are either cardiac tamponade or acute severe AR. So here you can see that there is no tamponade on transesophageal echo, but acute severe AR you cannot see because there's hardly any flow across the aortic valve. So this is a situation where the patient was immediately taken up on an ECMO, and we instituted ECMO. The patient had insufficient VT-VF. This is the initial ECG and the blood pressure, and this is the ECG and blood pressure on CPR. And the patient was immediately, ECMO was instituted in 10 minutes time. However, ECMO, as I said, is not the panacea, and you can see the left atrial, the right atrial cannula in the venous side, and the CPR is ongoing. Now the patient is on full support, standstill heart. The ECMO is giving support, but it is not sufficient to bail the patient out. You need to still make this valve competent. So that's how the valve was implanted at the aortic position, and once the valve was implanted, gradually the patient became better, and you can see that the contractility returns, the rhythm returns. The pressure, aortic pressure has a low pulsatility. That means a lot of support is being provided by the ECMO rather than the patient's own support, and the patient was shifted to recovery after this TAVR. Patient remained in severe acidosis earlier. Gradually the pH improved as the myocardium started picking up, and patient was weaned off ECMO after 84 hours, discharged 3 days later, and it was a miraculous survival for this patient. So what is the evidence in favor? Hardly any evidence. In fact, you can see that the cardiogenic shock patient, tandem heart versus IOBP, better hemodynamics, but there was no clinical benefit. The SHOCK 2 trial, which was presented in 2013 by Holger Thiele, there was hardly any difference in the mortality. In fact, IBP did not show any benefit over conventional treatment in this patient. Similarly, tandem heart versus IBP, better hemodynamics, but no benefit. Impella 2.5 versus IBP, better hemodynamics, but no long-term benefit. In high-risk PCI protect trial, in intention to treat basis, there was not much benefit, but as treated, Impella showed benefit in these patients. So guideline recommended in 2016, class 3 indication for intra-aortic balloon pump as a routine use in cardiogenic shock, and mechanical circulatory support is 2B indication as of now. However, if you use VO ECMO and you use SAVE score, you can get better prediction as to which patient are going to make it out of it. So this overall is a heart team approach, and you need to see patient on a clinical basis, and a team has to evaluate what is the best device for this patient, because you have a lot of options available. So to summarize, numerous devices are available and configurations are possible. Heart team experience needed for patient selection and device titration. Indication is severe refractory cardiogenic shock, as I already showed. The principle is to buy time for a definitive treatment. The guidelines say 2BC recommendation, no randomized morbidity mortality data, but judicious use may be considered. Selection for whom and when, indications and guidelines are not sufficient. You have to use your own risk markers and your experience for these sick group of patients. However, I would like to leave you with this thought that no patient deserves to die without a careful thought to circulatory support. Thank you very much.